I am so pleased that Dr. Martin Sepúlveda has joined us. He's rejoined us because he is an alum of our institution. He's an IBM Fellow, a member of the National Academy of Medicine, and the CEO of Claraluz, pronounced correctly?
Yes.
Thank you. An advisory and project consulting firm specializing in health data, analytics, technology, health, and health systems. His career in the IBM Corporation included serving in numerous capacities, including Vice President of Health Systems and Policy Research, Vice President of Integrated Health Services. He's led policy, strategy, health benefits, services and operations, occupational health, and well-being for IBM globally. Dr. Sepúlveda is widely recognized for his contributions in public health and population health, private sector healthcare, wellness, and health benefits innovation. He's led private sector collaboration with clinicians for medical home transformation, leading to formation of the Patient-Centered Primary Care Collaborative. I started by saying that he's an alum. He's returned home, and he is an alum of Harvard, having received both his MD and his MPH from Harvard. He earned his BA magna cum from Yale and completed residencies in internal medicine at UCSF hospitals and occupational and environmental medicine at the National Institute for Occupational Safety and Health. He also completed EIS, Epidemic Intelligence Service with the Centers for Disease Control. He's also done an internal medicine fellowship at the University of Iowa. Serves on several boards, several committees, has been deeply involved in changing our healthcare system, and is really positioned for where we need to go. And I'm so pleased that he's been willing to join us today. Dr. Sepúlveda.
I want to start by also thanking this extraordinary man. Alvin Poussaint is someone that students of color at HMS got to know very early on in their careers. Back then, he occupied an office in the psych building. This was probably a 6x6 office that had a desk and 2 chairs and not much else. And it was in that environment that he met people like us and helped us understand what the vision was for coming out of our communities that we were all really interested in going back and serving as we came out of undergraduate school, and how the world could be different if we stuck it out here for 4 years and picked up the knowledge and the skills and the tools and the networks, to then go out and pursue our passions. I'll make a point later on in the talk about the difference between seeing is believing and believing to see. And in a nutshell, this man helped us believe to see. And there is a quantum difference between both of those things and what they help you identify as opportunities to be able to make important changes. I also want to thank the men and women of the health institutions here for their passion and their persistence in keeping at the forefront of this institution the importance of having representation by underrepresented minorities. And for me, it's not just about ethnicity, it's not just about gender, it's not just about many of the things that we think about when we think about diversity. It's also about cognitive diversity. And my view is that having this kind of balance in this community is most important for bringing cognitive diversity to what goes on here. Because these folks, bring a view of the world and a set of experiences that's different. and it extends and expands the thinking of everybody that they interact with. So my thanks, to the students who wanted to ensure that this institution undergoes one of the most important leadership changes, that spot on the radar screen continued to shine brightly. In this lectureship, many people come and talked about what I would sort of capture as social justice issues. I'm not going to talk about social justice issues. There's enormous depth of social justice expertise in this room, and I probably couldn't tell you something that you haven't already heard. What I want to talk about is something very different, but let me start by making certain disclosures. I'm a retired senior executive physician in the IBM company. I spent almost 30 years there. I am now in my own company. I work for 5 companies, one of which is IBM Watson Health. They have nothing to do with me being here. I am receiving no compensation of any sort from any of those folks. I will make reference to very specific IBM technologies. It's because I know them and because they're reasonably unique technologies, and I show them for illustrative purposes only. I make no representation of their value. It's not for marketing purposes, and it's certainly not a product endorsement. So I want to sort of state that at the front end. So what am I going to talk about? I think that all of us who are here are on a life course journey in our professions. And we're going to encounter many different things, along that path. And what I'd like to do at the end of the day is just to kind of inform your journey by talking about 3 reasonably independent but interrelated things. One is the velocity of change in our world and time. One is cognitive computing and how that relates to the former. And the last is just to make some comments about how we think and how, if we're going to make the kinds of changes that we all are driven to make, it is as important for learning to unlearn. It's unlearning to learn. And those are the 3 kind of concepts that I want to talk about this afternoon. So let me start by having you just kind of sit back and reflect on the speed and the velocity of change in our world, what that means in terms of opportunities, apertures for opportunities, and how those apertures or opportunity are different today than they were yesterday with respect to the speed with which they open and close, right? The speed with which they open and close, which means that as we encounter these in our work in parallel, complementary, or adjacent spaces, we don't have a whole lot of time to decide, am I going to pursue that or not? Because that opportunity isn't going to be around very long, and you have to be cognizant of that. So let me take you through a 6-year period of evolution in the world in which we live, just to give you a visual sense of exactly how fast the world that we live is changing. So here we are in 2007, typical community gathering at an event. Could be a political speech, right? Could be a concert or some other event in the community, but if you took a picture of a community gathering in that time period, this is generally what it would look like. You fast forward a couple years, and this is what these community gatherings look like. Astounding speed and rate of change and penetration and diffusion of technologies that are allowing us to record things that we could never record with the speed with which we could record them, with the speed with which those things could be disseminated. That was change at the individual level. Let me give you a sense of the kind of change that's been occurring at the level of infrastructure in our societies. This is a typical long-distance commuter train in China in the year 2008. I look at Jerry over there as an avid train rider and Amtrak passenger. In 2008, our trains didn't look that much different. That was 2008 in China. Fast forward 6 years, that's what it looks like. China has implemented changes in areas of infrastructure like train transport that boggle the imagination. This system, in about 6 years, has more rail mileage laid than all of the railroad mileage in Europe. It has a reservation system that handles more transactions than all of the world's airlines combined. That's the magnitude of change that's occurred in some parts of our world from an infrastructure standpoint. Does anybody know what city this is? Shanghai. This is Shanghai. This is Shanghai. And the change of enormous speed has occurred at the level of cities. This is Shanghai in 1990. This is Shanghai in 2010. And this is a 6-year-old picture. And these changes have been enabled to a substantial degree by the use of data and information and technology. And these societies create massive quantities of data every day. World in which we live. The rate of generation of information in our world today is at about a level of 2.5 billion gigabytes each day. That's how much data we generate. And it's projected that in 4 years we'll be generating over 40 times that much information a day. Structured data, but mostly unstructured data. Images, video, speech. You all have heard about the IoT, the Internet of Things. Well, today, that Internet has over 1 trillion connected sensors and devices. And that number will continue to grow by leaps and bounds. In our world, in medicine, this is the kind of data world that we face. There are roughly 700,000 peer-reviewed medical journal articles published every year in our world out of a total of 2.5 million technical articles in science, technology, engineering, and math. Enormous volume of information. Recent calculations of where are we going to be in terms of the volume of information that's generated in medicine in the broad sense is that the half-life of knowledge in our profession is about 18 to 24 months. Knowledge turns over. And it's projected that in about 4 years, we're going to go from a half-life of 18 to 24 months to 73 days. That the half-life of knowledge for us is going to be that short. So how do we manage that information to know what we need to know, when we need to know it, to do the things we need to do with the people and the places where those things are going to occur? Well, we're going to need a lot of help, right? Because this volume of information is far in excess of human cognitive capabilities. And fortunately, and here's an example of the number of facts that are needed to be able to make decisions. This evaluation was done in the year 2007. It remains pretty accurate. You know, human cognitive capacity to make a decision based on phenotypic data is about 5 facts, right? And the expansion of technologies, particularly into the area of molecular, you know, and genomics and all the omics, are vastly and rapidly increasing the number of facts that are needed to be known to be able to make the decisions, clinical decisions at the individual level. Well, fortunately, there's been rapid advances in science and technology to manage data and information. Succinctly, we are now in an era of computing that is, in the technology world, often referred to as the cognitive computing era. And if you think of computing, you know, we come from a world of tabulating machines in the tabulating era, the creation of the transistor in the 1950s, right? And the spawning of chip-based computing machines that have allowed us to be able to handle large volumes of information, do phenomenal things, put people in space, build cities, all out of programmable computing. And programmable computing is code. Somebody has to write step-by-step instructions for the machine to be able to do that. And if you want the machine to do something else, you got to go back in and you got to rewrite the code, right? We're now in an era where machines can reprogram themselves, right? They have the capabilities largely through the advances in algorithmic mathematics, right, to be able to generate rules that are adaptive and flexible, and they respond to new sources of information. They respond to experiences that are provided by experts, and they iteratively improve themselves. You know, substantively, that is cognitive computing. It's all in this area called machine learning, where all of these different capabilities reside, and that coupled with advances in the science of natural language processing allow people to interact as humans interact with machines. In every earlier era of computing, we had to adapt to the user interface of the machine. And those early user interfaces were like, man, they were horrible, right? Apps and all of that stuff, it's like much better now, but still it's not natural, it's not intuitive. How do we communicate? You know, someone once pointed out to me that the 2 most effective means for transferring large amounts of complex information are, anybody want to guess what the first one is? It's art. It's art, pictures. And the second is language and speech. So the interaction with these machines is natural language. You talk to it. And you don't have to make up stuff. You talk to it as if you will be talking to someone in your profession on a technical subject. Now, these things have to be, you know, trained, right? The algorithms have to be written for that. The nuances and the context of a profession need to be integrated into the machine. But once that's done, you can interact with the machine in that fashion. So this is the locus of the assistance that we need to be able to manage the information to make the decisions that we need to make. So what is this thing called cognitive computing? How do you know cognitive computing from programmable computing when you see it? A number of years ago, these were the principal attributes that were articulated for you to be able, for all of us to be able to know. When we say cognitive computing, what are we talking about? Right? We're talking about computing systems that can handle massive quantities of very heterogeneous kinds of data. They take that data, they curate the data, they process it, they present it in a way that's highly interactive, using natural language processing with people, and they're learning systems. They learn. The more you use them, the better they become. The more data you give them, the better they become. The more expert training you give them, the better they become, right? But these systems are not for everyday pedestrian use. These are systems for situations that are like that are information intensive, information dynamic, information complex, where the exchanges are highly nuanced, and our profession is a highly nuanced profession. And there are situations where you want the interaction to result in the machine, giving you better stuff as a consequence of more data, renewing itself as new information becomes available, and it ingests it. And it has to be high value, high impact, because this is not cheap technology. It's like really expensive technology. Just to kind of, I'm not sure that if I didn't have the slide in there in this version, but I had one that showed two things. One is what the cost of the technology was over about a 10-year period, right? And I looked at personal computers, software, cell phones, wireless, and those kinds of technologies, and plotted out what happened to the price of those things over the first 10 years after their introduction. And underneath that was a graph that showed how many of those things entered the world in relationship to what the price was. And the principal point for all of the technologies was when these technologies come out, they're like really expensive, right? And not a lot of them diffuse into the marketplace. And so these are not democratized technologies when they're introduced into the world. They're technologies that are available to them that has. And them that has, that can solve the kinds of problems that they would pay high prices for. But over time, with competition, with advances in technology, unit price comes down, volumes go up, and the technology becomes democratized, right? So that today, people of low income, the penetration of smartphones, it's like really high, right? 4 years ago, it wasn't that high. They had phones, they had cell phones, but they weren't smartphones. Why? Because smartphones cost a whole lot more. But as the price comes down, then the technology diffuses. So one of the things I like to point out is that in this early phase of the evolution of cognitive computing, it's only going to be available in certain parts of our society to certain users. And one way to think about that is in the initial introduction of these technologies, disparities get greater. We increase disparities before we shrink disparities, but it will shrink disparities. And how quickly the price drops is going to be dependent on a whole lot of factors. And from my perspective, I think competition is going to be the principal driver. I'm going to talk a little bit about the cognitive computing technology, generally referred to as Watson Health. This cognitive computing technology, and you need to think about it as it's a mosaic of technologies. It isn't one thing. It's like a whole bunch of things. And some of those things can be used by themselves to provide a lot of value, right? And some of the applications of it include being able to help people get to a level of understanding faster than they ordinarily would have, because the part of the technology that can ingest information, that can standardize it, that can interpret it, that can summarize it and present it to you, means that you're not burdened with the challenge of doing the world's literature search to find everything you need to know about a particular subject. The machine can do that for you in seconds. And it can access information that might not be so easy for you to access, but that is public information, like by patents, right? Patents are public information. They're filed all over the world in different countries. How many of you have ever done literature searches on patents? Is there information in patents that can be valuable to what you're doing? Absolutely, right? So this can be employed for that kind of purposes. It's being used to help in the field of drug development identify target molecules faster, It's being used for learning. It's being used for training. It's being used to provide expert clinical decision support for certain in certain professions. And I wanted to give you an example. This is an application of this cognitive computing technology to the field of oncology and to the practice of an oncologist in an environment of dealing with a patient with cancer that can present, with a form, a stage, and a personal phenotype with this cancer that requires the oncologist, to be able to use different kinds of information.
Dr. Mark Norton, a clinical oncologist, is preparing to see a patient. He logs into the electronic medical record, and instead of spending time trying to find relevant information, he uses the IBM Watson Oncology Diagnosis and Treatment Advisor. He pushes the Ask Watson button, and Watson analyzes the patient data against tens of thousands of documents from its vast body of medical literature. Dr. Norton starts with the Case Information tab, where Watson has pulled out the relevant information, as well as suggestions for additional information to gather. Moving to the Test Options tab, he sees tests that Watson suggests that he consider ordering. He presses the Evidence button to see the reasons why Watson suggested the first test. Then he drills down further into a specific reference that supports the suggestion. Once the results of the tests come in, Dr. Norton presses the Treatment Options tab to see a panel of suggested confidence-scored treatments. He also sees a list of clinical trials to consider. Again, he reviews the supporting documentation by pushing the Evidence button. Dr. Norton has new information to add to the case, so he pushes the blue Watson avatar on the bottom and speaks directly into the microphone. He makes sure that his words have been transcribed correctly and submits the new information. Watson returns a revised set of confidence-scored treatment suggestions that take the new information into account. It also updates the list of clinical trials to consider. Shifting gears from Dr. Gordon's role to that of a hospital or health plan administrator, the advisor provides a customizable dashboard showing key performance indicators like where the advisor is being used, how it's performing, and what.
This kind of technology is early in its phase in the introduction in the marketplace. Oncology is an area where artificial intelligence or cognitive computing companies have focused for obvious reasons. It's complex. It's an area that's high on the list of priorities for healthcare, for addressing people problems, economic and systems issues, and where the rate of generation of new information is quite high. Let me shift now to how we think. There's a wonderful person in this institution. His name is Jerry Groopman. Anybody know Jerry Groopman? Jerome Groopman. Jerry Groopman was a medical resident when I was a medical student doing an internal medicine rotation at the Massachusetts General Hospital. Jerry Groopman was the most ill-fitting resident in the IBM system. He was just cut out of a different cloth. Okay, but became, a phenomenal physician, researcher, and an educator out west. And then we had the vision to bring him back home into the Harvard system. And he spent a lot of time thinking about how we think as doctors. And he's published a lot on it. For those of you who aren't familiar with his work, you really ought to look him up. But part of the way we think is anchored in knowledge and experiences of the past. So we look at the world through a certain set of lenses. Jerry says we are anchored, right? Our cognitive profile is anchored in those things. That's not a bad thing. But it also means that when you're confronted with something new and different, you approach it through the experiences that you've had and the lenses through which you view the world. And what I want to suggest to you now is that there are opportunities that you will never see, that you will never advantage if you don't, when it's appropriate, actively put down what you know and how you think of things and approach it from someone else's perspective completely. And it's what's often referred to as unlearning to learn. You know, not staying in the mode where the way your cognitive thinking advances is by layering on new facts, new experiences on top of what you already know. But it's really shattering that foundation and that platform, right? And proceeding from that point. And here's a phenomenal example of that. And it has to do with riding a bicycle. I'm sure that everybody in this room learned to ride a bicycle at one point in their lives.
Hey, it's me, Destin. Welcome back to Smarter Every Day. You've heard people say it's just like riding a bike, meaning it's really easy and you can't forget how to do it, right? But I did something. I did something that damaged my mind. It happened on the streets of Amsterdam, and I got really scared, honestly. I can't ride a bike like you can anymore. Before I show you the video of what happened, I need to tell you the backstory. Like many 6-year-olds with a MacGyver mullet, I learned how to ride a bike when I was really young. I had learned a life skill, and I was really proud of it. Everything changed, though, when my friend Barney called me 25 years later. Where I work, the welders are geniuses, and they like to play jokes on the engineers. He had a challenge for me. He had built a special bicycle, and he wanted me to try to ride it. He had only changed one thing. When you turn the handlebar to the left, the wheel goes to the right. When you turn it to the right, the wheel goes to the left. I thought this would be easy, so I hopped on the bike, ready to demonstrate how quickly I could conquer this.
And here he is, ladies and gentlemen, Mr. Destin Sandlin. First attempt riding the bicycle.
All right. So the faster I go, the better.
Yeah.
I couldn't do it. You can see that I'm laughing, but I'm actually really frustrated. In this moment, I had a really deep revelation. My thinking was in a rut. This bike revealed a very deep truth to me. I had the knowledge of how to operate the bike, but I did not have the understanding. Therefore, knowledge is not understanding. Look, I know what you're probably thinking. Destin's probably just an uncoordinated engineer and can't do it. But that's not the case at all. The algorithm that's associated with riding a bike in your brain is just that complicated. Think about it. Downwards force on the pedals, leaning your whole body, pulling and pushing the handlebars, gyroscopic precession in the wheels. Every single force is part of this algorithm. And if you change any one part, it affects the entire control system. I do not make definitive statements that often, but I'm telling you right now, you cannot ride this bicycle. You might think you can, but you can't. I know this because I'm often asked to speak at universities and conferences, and I take the bike with me. It's always the same. People think they're going to try some trick or they're just going to power through it. It doesn't work. Your brain cannot handle this. For instance, this guy, I offered him $200 just to ride this bike 10 feet across the stage. Everybody thought he could do it.
No, you didn't understand. You didn't understand. So, this way. All right, just a second. All right, so, whenever you're ready. Yeah. Quickly! No, you have to keep your feet on. Dude, look. All right, here we go. Like, you gotta start rolling at least. Okay, good. And go. Oh, go! All right, back up. Okay,
A personal challenge. I stayed out here in this driveway and I practiced about 5 minutes every day. My neighbors made fun of me. I had many wrecks, But after 8 months, this happened. One day I couldn't ride the bike, and the next day I could. It was like I could feel some kind of pathway in my brain that was now unlocked. It was really weird though. It's like there's this trail in my brain, but if I wasn't paying close enough attention to it, my brain would easily lose that neural path and jump back onto the old road it was more familiar with. Any small distractions at all, like a cell phone ringing in my pocket, would instantly throw my brain back to the old control algorithm and I would wreck. But at least I could ride it. My son...
I brought this up at the front end, and I wanted to repeat it yet again, and that is that, you know, we live in worlds and institutions that demand data. Show me the data. How many times hasn't anybody heard that, right? Show me the data, right? And when I see it, I'll believe it. When you show me the data, when I see it, I'll believe it. And that's really important. But there's another part that says that disruptive innovations and quantum transformations come not from data. They come from believing that whatever it is can be radically different than it is today. And then envisioning that and what the components could be like that make that work, and then working your way backward. And in the right situations, believing to see will identify opportunities that will otherwise be missed and left on the table. That is the world of startup technology companies. They don't have any data. They have data on it's a problem. They have absolutely no data on what that changed world could be, right? But they believe it could be different and it could look like this, and they carve out the part of it that they think they're capable of creating, and then they drive that. Not an easy thing to do. Not an easy thing to do, particularly as the more successful you become in some professions, the harder it is to be able to do this. But don't miss the opportunities for that. Look through somebody else's lenses, believe. As I said in the beginning, he didn't know it, but that was part of what Alvin Poussaint helped us with way back then, when we were saying we should be in our communities doing stuff that makes a difference in people's lives now. And he challenged us to look through a different set of lenses, believe that things could be radically different, right? Acquire the tools that we needed, and then envision that world and work backward. And I encourage you, because many of you interact with people in early and mid stages of their career, you know, to share this kind of perspective with them. I've been fortunate today to have the opportunity to sit down with clusters of people in different programs in different parts of their career, and probably this was the most, you know, meaningful thing that I shared with them today. Let me give you an example that I was personally involved in, where we really looked at things through a completely different set of lenses. And this was in the area of primary care. Our system, even today, is a specialty care driven system. Almost 3/4 of everything goes through specialty care. Almost 3/4 of physicians are specialists. Most of what gets done in medicine, most of the cost that's generated in medicine, all goes to specialty care. Right? We got primary care, but not a whole lot of it. Other countries have been smarter than we are. They've understood that healthcare systems based on primary care do better. Do better in a number of really important domains: health outcomes, financial outcomes, sustainability, equity. They do better, right? So here we are, I'm sitting in the IBM company around the year 2005. We've been facing in our company hefty double-digit increases in health insurance every year, right? On a base of about $1.2 billion. So you figure we see a 10% increase in cost this year, it's $120 million, right? You know how many contracts we have to sign to be able to generate $120 million to pay for that health care? A lot, right? And so part of my job was figure out how to have a healthy employee population, how to have happy employees, how to have them want to stay with our company because we really care about them. But man, you got to take a lot of cost out of this company, right? And if you don't do it, we know how to do it. We may not meet all those objectives, but we know how to take money out of this business. And we have done some phenomenal things. You know, we were the first large employer to take what we now call care management, right? And coordinated care. We introduced that into the large employer marketplace around the year 2003, 2004. We did it first with behavioral health because we understood that people with behavioral health issues were the most complicated, were the most disabled, and were the most dysfunctional and cost our company the most amount of money in a holistic sense. I don't mean healthcare, I mean they weren't at work, or they were in client environments, but they weren't performing the way they needed to perform for us to be able to make those clients happy and to grow our business in those client environments, right? They created dysfunctions in teams, right? So we understood that behavioral health was like massive. So we did it around behavioral health, and then we did it around chronic diseases. I share a story with you, I won't name the name, but it was one of the Fortune 5 companies. In those years, there weren't many people like me who sat on top of corporations doing this thing, but he did in his company. And I had the most heated debates with him because I told him that we need to get together and develop systems for care coordination and managing chronic diseases. This was in the year 2003. And he said, it doesn't work. And here are the 15 reasons why it isn't going to work, and we're not going to do it. I said, okay, don't, 5 years from now, don't tell me I didn't give you the opportunity to be at the front end of this stuff. So we did it, and we created the systems and the platforms with our insurers that then they integrated into service components of their business to better serve their clients and deliver better outcomes. And it was a view of primary care that was different. And this was an employer. So here's the history of primary care up until, we used to call it PPACA back then, but it became known as the Affordable Care Act, or ACA, in 2010. Pediatricians, they understood the importance of comprehensive coordinated care. And they developed this concept of the medical home in the 1960s around children with special needs, really complicated patients and families. This concept slowly diffused, in our country. Surgeon General wrote a major report on it in 1987. Calvin Sia in the state of Hawaii did phenomenal things with this for the underserved poor people of Hawaii. In 2002, a landmark report came out of the American Academy of Family Physicians. They said we need to transform how primary care is delivered by family physicians, and the model was the model of the medical home. A couple of years later, the internists came to the same conclusion. They produced this document that said we have to transform the practice of internal medicine around this thing they call the advanced medical home. So I'm sitting there in this corporation, I'm seeing this, I believe it, right? I believe it, I envision what it could be. I go to these professional organizations who were not having success lobbying for support for these kinds of transformations with payers, both public payers, namely the government, and private payers. They say, we ain't paying for this. You know, I need to see it to believe it, right? I'm up to here trying to manage double-digit costs, right, and keep the clients that I have. So we went to them and we said, look, we believe, you know, this is an important part of the transformation of our healthcare delivery system. We're going to commit to you that the IBM company will take its brand and will recruit other notable employers and take the concept of the medical home to legislators in Congress. And we think we can convince them to support this. Why? Because we're like them. We pay half the bill, they pay half the bill. We see double-digit inflation, they see double-digit inflation. We got shared pain here of enormous magnitude. The only time they ever saw you guys there was lobbying for higher reimbursements. That's the only time they ever saw you there. They never saw you there for transforming how you do things, for increasing the value, for lowering the cost, and for improving outcomes. The only time they saw you there was for lobbying for higher rates of reimbursement. And you've got something that is really powerful, right? But you can't carry this message because you're not a credible messenger. And it was like a hard thing for them, but they agreed because they weren't having success. And we said, so here's the deal. This is the business deal. You're going to have to do several things, and if you do those things, then we'll go and do this stuff for you. And the things that you need to do is, number one, you need to stop squawking and fighting amongst each other, because the pediatricians are fighting the family physicians are fighting the internists, and the osteopaths are trying to figure out what the hell is going on here, right? And so there's a pediatric version of the medical home, there's a family medicine version of the medical home, there's an internal medicine version of the medical home, and I, as a buyer, I need one version, because I'm not going to go to my population and say, if you live in New York, you're going to get this version, and if you live in California, you're going to get that version, because we treat all of our workforce the same, and our employees are global and they're mobile. They may be in California, but they may spend their time working in North Carolina, right? So they got to have the same version. If you're willing to get together and come out with one version of this thing, then that's one of the requirements, right? Another of the requirements was, we need to change your taxonomy and your language because it doesn't resonate in the private sector. So we're going to teach you how to do that. We're going to teach you business, concepts, business language, and you're going to frame this stuff in ways that business people can understand, and you're going to frame this in ways that politicians can understand. And we have a lot of experience with politicians, right? We'll make that kind of a contribution to you. And the third was, we need to build some quality metrics around this so we can measure this stuff. And if you're prepared to do those three things, we commit to you that we'll put the power of our brand around this, and we'll take this concept, into the sectors that were policymakers making decisions about where healthcare was going to be delivered, how it's going to be delivered, and how it's going to be paid for. And it was a phenomenal success story. It was a phenomenal success story. From that point onward, within a year, we created the Patient-Centered Primary Care Collaborative, which was a concept that says, this is an organization that's going to drive this. It's going to have two kinds of members. It's going to have the people who deliver the service, and it's going to have the people who pay for the service without any of those intermediaries, right? So it's all about AAP, AAFP, ACP, AOA, and companies. The IBM company, the FedEx company, Boeing, really marquee companies. There were about 17 companies that we brought to the table, and we went to Washington and lobbied for the medical home, and it became a pillar of healthcare transformation, right? It became a focus for the Medicare Innovation Center and those grants. It resulted in really significant increases in reimbursements to primary care physicians under ACA. It it connected with the HITECH Act, right, and changes that the HITECH Act brought to electronic medical records and digital information in healthcare. Just an example of looking through a different set of lenses, thinking about things very different. I mean, I can tell you, when I first went to our chief financial officer in our company and he talked about this, he looked at me like I was crazy, right? But when I went to see him, I went to see him with a story and a set of metrics and a set of commitments, right? And money. So I wasn't there asking him for money, and he loved that more than anything. Because anytime anybody sees a CFO, it's about money, getting more money. And I said, I can fund this. And he said, well, how are you going to fund it? And I said, well, you know how I'm taking 15% out of my $1.5 billion budget next year? If I take out 18%, I want one of those percentages to help fund this. Will you do that? And he said, I gave you a 15% target. If you can take out 18%, you want 1%? It was a quick calculation. He said, yes. So this is the kind of stuff that can happen. Subsequent to that, in the year 2010, we were the first in the large commercial insurance marketplace to make primary care free. We decided in the plans that I designed that primary care was going to be free. So if you went to your primary care doctor, you didn't have to pay for that. And this was in markets where you could go to anybody. So it wasn't like an HMO, or it wasn't a restricted network where you had to go to those 5 doctors over there. It's like you can go to any primary care doctor you want, anywhere in the country. You go there, the charges for the physician in that office visit is free. You don't have to pay for them, right? And what I want to show you is what happened. And I got to tell you, I got to be honest with you, I believed and I saw, but I wouldn't necessarily have mortgaged my children's college tuition on the results. But these were the results that we got. A population of 25,000 children observed over 4 years, continuously enrolled in the same insurance plan all around the country, that free primary care resulted in a massive increase in primary care visits, a significant decrease in specialist visits, decrease to emergency rooms, decreased prescription drug fills, and it didn't cost the company a penny. We didn't save money on the kids, but we delivered a whole hell of a lot of value. And I can't tell you how much value we got out of the people in the company for what it was we were doing for them and their children. Here, the results for adults were even more outstanding. These data are in review now for publication, but the results in adults were identical, except that we saved a ton of money on the adults. We didn't save money on the kids, but we saved a lot of money on the adults. We saved on the order of about $400 per enrollee who was an adult in our healthcare plans per year, making primary care free. People didn't need to go to emergency rooms. People didn't need to go to specialists. Hospitalizations went down. And very interesting, and maybe if you have some thoughts on it, but our study wasn't designed to answer the question. Here's what happened with primary care visits. We segmented primary care visits into preventive primary care visits and all other visits, okay? So acute, chronic, all of that stuff was in the other category, and all preventive visits were here. And we used standard codes, right? CPT codes for identifying what those were. And this was a surprise to us, because when we looked at the kids, their preventive visits went up and all other visits went up. When we looked at adults, preventive visits shot up in primary care and non-preventive visits went down by a lot. So the dynamic in adults was this incented preventive visits, and there were few non-preventive visits in primary care just as there were in specialists. And we gave that a lot of thought, but our study was not designed to be able to get at the kinds of questions that you would like, because we were matched at the aggregate population level. We couldn't begin to segment people, right? We would violate all kinds of comparability. Our controls would be lost, and all of that sort of thing. So it's speculative on why that happened, but it was a good thing. So let me close, since you folks are going to be going to dinner, giving you an illustration of how cognitive computing is being used for discovery and creativity in the culinary arts, in food, one of our favorite things.
Very interesting.
Like I said, something new, something different. Definitely great.
It definitely is a shock that the recipes and the ingredients were selected by, a computer.
I'm James Bricione, and I'm the Director of Culinary Development here at the Institute of Culinary Education.
I'm Michael Asconis. I'm Creative Director at the Institute of Culinary Education.
As a chef, creativity, I think, is one of the most important things. So I think it's something that everybody strives for in their careers, is to learn that skill of creativity and how to develop and cook new things.
The idea of creative computing is for machines and humans work together. In this case, for the machine to work with chefs to put together new recipes that has never been put together before.
So humans have trouble remembering or thinking about large data sets or large numbers of possibilities. Most professional chefs are good at reasoning about pairs of ingredients. Some of the best chefs can reason about 3 ingredients, but pretty much no human can reason about 4 ingredients. And that's where the power of the machine comes in.
Working with the system begins with designing the dish. We select first an ingredient that we find interesting or intriguing. We set up some parameters of the dish, what types of ingredients we want to include, and then we spin the wheel and wait to see what comes out.
If you think about all the possible ingredients in the world to put together for food, there are quintillion possibilities.
So when you put in a key ingredient, the system will start to think about which ingredients often go well together. It'll start looking at regional cuisines, and it'll come up with these thousands or millions of ideas. And then that's where the psychology and chemistry comes into play. People often think of food as an art, but in fact there's a lot of underlying science. And what the machine does is it models both aspects. It understands the chemistry of the food, but also models human perception, and so it can predict what will be flavorful or not.
Tonight, the system gave us a Cuban lobster bouillabaisse to cook, which was a great challenge.
The few things that kind of interested me right away were the use of the squash. I'm sure I've had lobster with squash before, but not really in that sort of Latin context.
I feel pretty confident saying that we were the first 2 to ever create a Cuban lobster bouillabaisse.
Let me close by suggesting a couple of references for those of you who are interested. The science issue is a phenomenal issue with about a dozen articles addressing a broad array of developments and applications of cognitive computing or artificial intelligence. It's a phenomenal read. The book on the right is a very interesting book by the person who led a lot of the Watson development in the IBM research division, talking about cognitive computing and smart machines, its beauty, its shortcomings, its faults, its deficiencies, and its scientific needs that are required to be able to realize higher levels of value from this technology. So there's a lot of science that's needed to advance this stuff. And the one on the left, I'm not a computer scientist, but I wanted to understand what machine learning is all about. And this is a machine learning book for poets. And you really learn a lot of good stuff about this. It was written by one of the machine learning giants who's just down the road here at MIT. So with that, thank you for coming here. I know you're all really busy people. I hope that there is something something in what I've covered this afternoon, that you take back and think about, and and maybe even deploy. And again, the take-home messages are: we live in a world of high-velocity change. Opportunities are unprecedented in number, but they open and they close really fast, right? Take risks, because that opportunity won't be there tomorrow. Cognitive computing is going to change our world, but it ain't going to change it tomorrow. It ain't going to change it, radically 5 years from now. The technology needs a lot of scientific advances, and the price point has to come down, right, in order for it to diffuse in many more different areas. And lastly, pick up someone else's lenses and try and view the world that way. So with that, thank you. It's been a lot of fun for me. Thank you for having me.
So I want to thank you. There's two parts here. I want to have an opportunity for some questions, but I'm also looking at the time. People have to go, and there's an important part of this that I also want to turn to. So I'm going to turn to that part, and you will be here after this for reception for more questions and comments. This is an important event for us here at Harvard Medical School, honoring Dr. Alvin Poussaint and all that he's done, and you've spoken about Dr. Poussaint. We're pleased to bring this lectureship here. We're pleased to co-sponsor this with Massachusetts General Hospital and their Center for Diversity and Inclusion, but also want to mention some of the other parts of the medical school that are deeply involved, and that's the Office for Recruitment and Multicultural Affairs, and the representatives here from Dr. Poussaint, those from Program in Medical Education, Nancy Oriel, who also serves on our Poussaint Advisory Committee, Fidencio Saldana, who is our Dean of Students now and was formerly in the Office for Recruitment and Multicultural Affairs. But this is an important event where we bring alums back to Harvard Medical School to have an opportunity to meet with our students, to meet with our fellows, to honor Alvin, and to honor the potential, this bringing this believing together with seeing and doing. And you've brought it out beautifully. I think what you have described here really speaks to what Dr. Poussaint has done for so many of us. There's a long introduction here for Dr. Poussaint. I'm not going to read it all. We know that he's professor of psychiatry. There's a whole nother hour. He applauded. He's professor of psychiatry and faculty associate dean for student affairs. He's been instrumental in expanding the enrollment of underrepresented medical students at Harvard and integrating them into the school, encouraging mentoring for them, and helping them to launch their careers as physicians. He's the author of numerous books on child psychiatry with a particular focus on raising African American children, and an expert on race relations in America, the dynamics of prejudice, the issues of diversity as our society becomes increasingly multicultural. He's had a long history. He's made a difference, not just in Harvard Medical School and not just in medicine, but to our entire country. He was a pioneer in our civil rights movement, being where he needed to be and making a difference. He first came back to Boston and was at Tufts Medical School, and then I'm going to say you saw the light and came on over. That might not be how they see it. You had to enlighten and came this way. He's a distinguished fellow of the American Psychiatric Association and a fellow of the American Association for the Advancement of Science, a life member of the American Academy of Child and Adolescent Psychiatry. And all of these things are absolutely wonderful, but more importantly, he is someone who mentors all of us, who guides all of us, who gives wisdom and word. And with that, I'd like for you to come forward. Dr. Poussaint. So that you might give this award to Dr. Sepúlveda.
Oh, my.
This is an award for Martin Sepúlveda. The one thing I want to say about him, I talked to him today, and I found that we grew up 2 blocks from each other in East Harlem, New York. I lived on East 101st Street, and he lived on East 99th Street. And East Harlem was mostly a Puerto Rican neighborhood, so he was where he should be. I was too.
Thank you.